Thank you for having us this afternoon. It's really hard to come after everybody has spoken today. It feels like, I suppose our background being nurse practitioners is we register nurses first, which even though we've moved into an advanced sort of practice level, we kind of still think like nurses, which I think makes us unique, especially in a population such as prison health. In myself and Annette, and we have a third nurse practitioner, work across 7 sites?
6 sites. So there are 7 prisons and we work for 6.
And today our topic will give you an insight of what our role is. And I've just been thinking about everything that we've been talking about today and how we are, in our own way, trying to do that. I've got, I think the back table there has got a lot of nurses that come with us from prison health as well. So a lot of our work is supported by the work that they do. Because on our own, we wouldn't be able to do as much as we're doing at the moment.
We don't know how to do this. Oh, we did it.
She did it. Just like how she roped me into this presentation. I'm not very good at public speaking, but she's made it one of my bucket lists for 2025, so here we go. But it's easier to do when you're talking about something that you do every day, so it's not a new topic, so hence why I humored her and I'm here. In terms of the kind of healthcare that we provide, we're primarily a primary healthcare service. We've talked about, the whole day has been about mental health and the challenges that people, who live with mental health face. But there's an additional layer for people who've been in prison or are in prison on top of having mental health issues. The complexity arises from, a high prevalence of chronic disease. We've talked about, people who live with a mental health illness having, 5 times higher premature death in terms of compared to people who don't live with a mental health disorder. There's substance use disorders that people live with, and also just the impact of cultural diversity in a prison system. Although every aspect of our care is being acknowledged by the Australian government, we work in a very confined space. We work alongside correctional services who are there to do a different job, completely different to what we do. I often have people ask me, how do you work in prison? Oh my God, that must be, you must be so scared every day. My 14-year-old son said, you work in a prison? I was like, how are you finding this just out now? Because, I've worked there for a while now. But the truth of the matter is every day, health professionals see someone, even in the community, you don't know a lot about that person. And you don't need to know much to help them come and get a health service done. And it's the same thing that we do. So we don't need to know why they're there in prison. We're there to provide a health service which is equal to what community provides. We have limitations, like I said, and they also are a complex cohort based on, health literacy. This morning someone talked about, privilege of having health literacy, knowing when to go to the doctor. Now, if you're someone who's living with a mental illness that hasn't been taken care of and you're living on the streets and, sometimes at no fault of your own, you've committed a crime and now you're in prison, that adds an extra layer. You're homeless and now you're in prison and you're going to serve your time and then you go out back to the same circumstances that you had. So a lot of people that we do see, being in prison gives them a chance to actually get the help that they sometimes don't know they need. Because they've had poor, interactions with service delivery, and sometimes someone mentioned the word discrimination earlier, and again, inadvertently, sometimes there is this notion that, you should know, you're an adult now, you should make better choices, but some people just were not set out in a way that equipped them to be able to make better choices. And again, when they come into prison, I think, if I'm not mistaken, we do have a very good screening tool in terms of prison health, where people come in, we offer bloods, which is opportunistic, but we've been able to pick up Hep C, we've been able to treat HIV, put people on treatment. the issue sometimes arises that connection where we've set people up. And again, most people will call to see a GP when they are unwell, when there is a crisis. But the opportunity of calling a doctor to go and do a 6-month checkup, most people, don't go to the GP when they're well. We sometimes have that opportunity where, yes, someone's in crisis, they've just been arrested and they've come to see you for whatever reason, to have their medications charted or whatever. But we do have some time while they're in prison to follow up with, healthcare stuff and be able to talk to them after they've been sentenced and they're not as anxious as they were when they first came in, where everything was going, above their heads. And you have opportunities then to do preventative health and health promotion. So there are people, that we've seen who've come in, but because of the education that they get from the nurses and the time that they get from us and our GPs, we're not a well-oiled machine, and definitely there is lots of room for improvement, but we do that really well in terms of taking the time to do that preventative health education, that people know, oh yeah, I could have gone to the doctor for this, or while I'm here, I can have this done. So this is a question that usually throws people off when they come to see me. I say, what can I do for you? And they go, you called me. And the thing is, when we have a clinic list, there's a list that the nurse books the patient in for. So overdue pap smear. But that may not be important to that person when they come in to see you. Something else might be happening. Again, if we look at, there could be socioeconomic disadvantages. There could be kids that are in DCP care. There could be, I was arrested and I don't know where my stuff is, or is it safe or someone's going to access it. So there's other things that also play a part in their mental health. Not necessarily complex mental health, but regardless, mental health issues that are impacted by being in prison. In terms of our roles as nurse practitioners, we kind of are a jack of all trades, but master of none. We make it work, and like I said, we think like nurses first. So someone may come in for something and they end up with other things that they didn't even know they needed, because we get sidetracked and we go, oh, but you could also need this. Oh, but this would also be helpful for you. And again, the uptake is different depending on interest, engagement, what else is going. They've got court tomorrow, so maybe that's not the right time to bring up that conversation. But every opportunity that we have, we take it to either deal with what's happening or preventative care or health promotion, so that people know that there is an option there. So you'll find sometimes, unfortunately, there are people who come into prison, more frequently, and we probably have their health records, because that's when they have that interaction with health services. Because on the outside, even for us, I used to work in a GP practice that was in a shopping mall. And it kind of makes sense that you would just do your shopping before you go home, because there's a supermarket there. But it's also a bad thing, because then you've been talking about all these healthy lifestyle choices, but your trolley, the patients are seeing you with your trolley full of all the stuff you said they shouldn't have. So again, it's that kind of thing of not only practicing what you preach, but also taking the time to put yourself in somebody else's shoes. Is now the time that I would get the most out of this. So like I said, we have limitations in how we work and how we do our jobs. There could be lockdowns. When you have a list for a clinic, they have limited time that they have access to healthcare, and you've got to make every opportunity that you have with someone count, because sometimes you're the only person they're going to see. And if you don't establish a positive, encounter, it also kind of influences their next encounter with the next person. And they already sometimes have a preconceived notion of, you're not going to listen to me anyway. And so you're starting from scratch, trying to establish that relationship of, I'm here to help you. What is it that I can do for you? The nurses want me to talk to you about your asthma. How do you think you're going? Is there anything else? And again, that sometimes opens a can of worms and, again, limited with what we can do. But it opens up that rapport and enables that person to know that they can talk to you. In terms of our roles as nurse practitioners, we're not doctors. We certainly don't get paid as ones. But We also have that approach of a nursing approach where it's not just I have 10 minutes and I'm just going to do what I need to do. It's also what else can we fix while we're here? Because sometimes you don't know what you don't know. So if you've never encountered something, you don't know it's a problem. You've never had your blood pressure checked before. It's an opportunity to have someone have their blood pressure checked and have that discussion about, cardiovascular risk and where that's going. Because sometimes, like I said, you only go to the doctor when you're unwell. You don't necessarily go, if you didn't get that text message to remind you about your pap smear, your cervical screening, you probably wouldn't volunteer for it. So it's kind of the same thing. In terms of our roles, we initiate medications and access and refer patients as needed. We, like I said, the nurses do a really good job when people come in. We do blood tests to check their health bloods. We do BBV screening because there's a higher risk of risky behaviors, drug and alcohol abuse, sex work. So there's a lot more risk that's happening that we screen for when people come in. Sometimes people come in to, for a short space of time, so they may not get to see the nurse practitioner or the doctor, but that screening has been done by the nurses, and it's something that we have a baseline of, and we can follow from that. We participate in a lot of health promotion activities, and as much as we're educating our patients as we go, we're also participating in things like Hep C, and vaccinations. We have a solid opioid substitution program, which, we've seen change lives for people, because some people have never been off drugs. This is the first time they're in prison. This is the first time they haven't been able to cope or have something to help them mask it. So now they're facing it, so their mental health is compromised even more, because now they're sober to face it, and they're being sober in a place where they're already restricted in terms of their movement and what they can and can't do. We are also cheaper than GPs, so just something for the policymakers to, in the room, to note, that we do go above and beyond for less. For example, in our service, each nurse practitioner will probably see about 3,000 people a year. We do have limitations. Like I said, we have access to people 4 hours a day, and the number of people in prison are a lot. So again, we have a process where people can request medical treatment. In our practice, when you see someone, you request a follow-up, because they may not request a follow-up, they may not see a need for a follow-up. But it's another interaction that you have in a space for them to go and think about what you said, and for you to reinforce what you said last time, something they not necessarily would follow if they were on the outside. Because again, as we all know, and we're not in prison, life takes over, and it becomes, well, my BP was okay last time, and I don't feel unwell, so I'm gonna do this because that's the priority on the day. And again, it is a prison still, so we have to think about safety, and we have to be realistic about certain things. So for example, we don't have our mobile phones during the day, which actually turns out not to be a bad thing, because I can always say, I'm at work, I don't know. My kids email me and I go, I was so busy, I never saw it. No, I'm not telling you what we're having for dinner, figure it out amongst yourselves. But, we do have to think and be conscious about our safety and the safety of other people. So, medications in glass bottles, and sharps, where you put the scissors, where you put your car keys. So there's things that you still have to be conscious of, but again, keeping in mind that when we see our patients, we see them as patients. They're not prisoners to us, because that's not the role that we're there to perform. We advocate for our patients, and I think because nurses spend a lot more time that is positive with the patients, we have a lot of respect that we get from nurses, and I think that extends to us. Even though we don't see our patients all the time, the nurses do. So the nurses know them really well. So, if you ask a nurse about this prisoner, they'll be able to tell you a lot more about that person, because they see them on a daily basis. So you can tailor make the care for the person that you're dealing with. Or, they have a problem with authority, or they have a problem with this, or, he gets easily triggered about this. So you kind of get the tips from the nurses who spend most of the time with them, which helps our practice and establish that ongoing rapport which we do hope continues in the community when they get out, because it's a matter of them finding someone they can have that relationship with. But at least now they know it's possible to have a relationship like that with a health professional. Again, if we think about the complexity of culture, and English is a second language, a good cohort of our group is Indigenous, and also we have people from different cultures as well, which sometimes makes it hard because most of the customer reference information is in English. So we get creative in how we get the message across, and again, different levels of expressing the same thing to make sure that, you know, the patient understands. We navigate resources and diagnostic limitations, because it's not just about ordering an ultrasound. You got to think about how they're going to get there. There's negotiations in the background happening about a simple request, because there's security that has to be involved, there's clearances that are needed, and so it's not as easy as, we need this urgently, can it be done in the next hour? Because no, actually it's locked down in the next hour. So again, it's working within the limitations that we face every day. In terms of, I'd like to think that we offer a culturally sensitive program. I think I was in a session earlier and we were asked to choose how we wanted to see things based on, you know, what you do. Are you a nurse? Are you a psychologist? Are you a... And I've recently embraced the term carer, which I never thought I was before, because I'm a nurse. So I'm good. I know the information the doctor's going to tell me, so I'm going to be fine. But my youngest son is nonverbal, and I've had to advocate for him and make myself heard in the console, because he's a child. I'm just given the information. It's not always explained to me. It's, this is what you need to know. And it's not about how is it going to affect you when you get out of this room, because now you've got this information, but what do I do about it? Which has changed the way that I practice when I speak to people, because it's easy talking about lifestyle changes and diet and exercise, but is it practical for the person that's sitting in front of you? Maybe, you know, it's not going to be 3 serves of fruit and veg, 5 serves of fruit and veg. It's going to be, we're just going to cut down on the chocolate cake, and that is a goal in itself. And again, some of the medications, someone has already talked about the medications that we give people that we know will cause significant health outcomes. Prison is hard for anyone, but add mental health illness to it. We were talking about earlier in another session about how, you know, it's diet, lifestyle, exercise, sleep. Those are the first sort of pillars of how you tackle mental illness. But those are the things that they absolutely have no control over in prison. So again, it's working with what you've got in front of you. And sometimes, like someone said, I'm not going to name them, but somebody told me earlier about how, you know, they've been giving prisoners printouts of what they can do in their cells if they can't exercise, because they're limited in the number of hours they can get outside. And I thought that was pretty cool, that you're able to actually give them options that they can do. So you don't need a gym membership. You could actually just use your water bottle, she said. I was like, yeah, I could do that. Am I going to do that? But again, it's that information and that informed decision-making that you've actually empowered someone to know, I could do that. And now it's a choice if they want to do it or not, which we all have. And that choice should not be taken away because they're in prison. Again, there's so many preventable health... There's so many preventable... I talk too much. This is why you shouldn't have let me go first. But
I am the smart one.
And I'm the loud one she drags along. But then again, it's, you know, like I've said, it's about, is this a problem for me or for you? And if it's a problem for you, then it should be a problem for me, and we should be able to figure out how to do that. I'll let you take over.
Okay.
Like you wanted to.
I only have 5 minutes. Imagine that. Like, I became so happy. That's why I became so happy. I only have 5 minutes. So I'm just going to jump very quickly into the patient stories, just so that you could read it. And I'm just going to give you a little bit of an insight, even if you're reading the patient story. So a bit of a background when it comes to prison health. When we service our prisoners, there is a time a big time management that we need to be able to work with. So even if we could prescribe medications, even if we work like GPs and we are not GPs, or even if the GPs prescribe the medications, there are certain times that patients could only access their medications. They could not access their medications before 8:30 in the morning. Even if they're a diabetic, they're not able to access their medications after 3:30 or 4 o'clock in the afternoon, even if they're a diabetic in the middle of the night. I'm not saying that worst case scenarios, these patients could not get their medications, but in the real prison setting, however you as a clinician outside expect your patients to be able to adapt to the suggestions that you give them to have better mental health, a better lifestyle. In prison health, unfortunately, these things couldn't happen, not just because they are within prison, but because we work under DCS, which is the Department of Correctional Services. So one of the things that when Shannon this morning was talking about, we turned a blind eye. Unfortunately, sometimes while we're working, we turn a blind eye with the things that we have prescribed that haven't been given. And unfortunately, the prisoners end up getting the consequence of it, And how do we bridge this? If we add another bridge to here is a problem and here is a solution, there is a why and there is, a how. How do you even make it happen? Sometimes we end up getting the brunt of, you didn't do your job well. All the nurses, all the doctors, all the medical team, we are trying to do our jobs well. The officers are trying to do their jobs well. Unfortunately, these two don't talk together properly because these are two different institutions. One is talking about safety and one is talking about healthcare. And so even as nurse practitioners, one of the things that when Thelma was saying, that the patients would say oh, so you were here to call me, you're here to actually listen to what I need, and outside I need to run after someone and ask for help. In prison, it's that bit where it's they now see healthcare practitioners as people who do care because we do take the time to sit down and say, it is your time, you are supposed to be here, you're supposed to be talking to us, and we're supposed to be giving you services because you are a human being, and yes, you've committed a crime, but you're not here in front of me telling me that you've murdered someone or you've raped someone, and I need to fix you for your diabetes. It's you are human, and that bit of information has nothing to do with your diabetes. So how could I help you? And how could I make, even this equity of healthcare be provided to you, even if you are seen and being forgotten outside because you are a nuisance to society? So it's just that bit where trying to remember that when we are trying to do healthcare services, most of the time we know the stories of our patients because they came in because of domestic violence, because they were raped or whatnot. But imagine life on the other side when we are talking to the people who has raped that person, and then they don't think that they deserve to even be treated. And now we are treating them, and then now they're seeing us as people who could help them, and that we're extending their life expectancy because they deserve to have a better life. Yes, it is not a better life in prison, but if you could change the way, as a consumer in prison, because not all prisoners will be in prison. Almost 95% of our prisoners will be released. You don't know that next Tinder person that you're talking to was actually a previous prisoner, But the truth is, how many times would you even ask that person, have you ever been in prison? Most of the time, nowadays, we would ask, where do you live? What have you done?
What car do you drive?
Yeah. We exactly, we don't ask, have you ever been in prison? Or would you ever think of yourself being a prisoner one day? So how would you change your conversations? So just being able to hear our prisoners really say that I feel heard, and I feel that, when I do go out, I'm actually going to look for, sometimes they would ask, I don't have a GP when I go out, could I find you? Of course, now you could say oh, please don't find me, please don't find me. The truth is they could find you, and they could ask for your help. But it's also that bit where it's how do we then continue even providing care that's hopefully they don't come back to prison. So as nurse practitioners, we are transforming custodial healthcare by delivering high quality, culturally safe, and patient-centered services. Our role is to ensure continuity, accessibility, and responsiveness in managing complex chronic diseases. The truth is, this is not just for prison health. As nurse practitioners, this is what we advocate for. We always, always, always advocate for our patients. And I know that the eyes are getting big because I think I've run out of time. So if you have any questions, please come up to us and please ask us questions.
Before we finally, if we could get one minute for you to read this quote.
Oh, yes, please. Only 1 minute because you guys read fast. Thank you very much for listening. Everybody's smart. They don't need to ask any questions. Thank you so much. Oh,
As someone that's been in prison, a lot of people choose your guys' work are the healthiest they've ever been and the healthiest they will ever be again. You do a good job and it makes a huge difference. And I work in reintegration now and people are in WA, I don't know about there, they are starting to carry on, especially the substance use treatment, starting to engage with us in community outreach, getting a bit of success. Housing again, still a huge problem, but thank you for what you do.
Thank you for saying that.
yeah.